All right. Thank you very much for the kind introduction. So, what I'll be taking you through in the next 12 to 14 minutes is the newer vistas in the management of diabetic kidney disease, a perspective from the endocrinologist. We are moving from a glucose-centric to a pathophysiology-based, individualized, holistic treatment model in patients for type 2 diabetes. And because we have common pathogenesis for a lot of complications of type 2 diabetes, physicians, endocrinologists, cardiologists, nephrologists, hematologists would be treating each other's specialties now, and we should know each other's specialty to some extent now. The management of CKD, we know it's a multifactorial treatment, exercise, nutrition, smoking cessation, glycemic control, blood pressure control, lipid management would be there for all patients. SGLT2 inhibitors, RAS blockade would be for more patients, most patients, as also GLP-1 receptor agonist should be there. Antiplatelet therapy will be there for some patients. Now, as we manage hyperglycemia in patients with CKD, what is important is that our goals get less stringent if there are risks potentially associated with hypoglycemia or the drug adverse effects. So we have to have drugs that have very low risk of hypoglycemia, which have glucose-dependent insulin release or are insulin-independent mechanisms. If the disease duration increases, we are less stringent. Life expectancy is low, we're less stringent. We've got important comorbid conditions. Hypoglycemia can increase the risk of comorbid conditions, morbidity, mortality. We would be less stringent in the joint target, establish cardiovascular complications, a patient who is less motivated, poor self-care capabilities, and a limited resource setting, again, would make our targets less stringent. If you look at data, you find that if you look at primary and secondary renal outcomes, end-stage kidney disease, renal death, EGFR less than 30, macroalbuminuria, and the secondary outcomes of microalbuminuria, and you look at more intensive glycemic control versus less intensive glycemic control, you realize that for all these primary outcomes and secondary outcomes, it all favors more intensive glycemic control. And now we know from the UKPDS data that if you have very good glycemic control very early in the course of type 2 diabetes, you achieve what is called the good glycemic legacy that persists even if the glycemic control is lost in the later stages. Look at the secondary albuminuria outcomes, macro to normo, macro to microalbuminuria, normoalbuminuria, micro to normo, or maintenance of normoalbuminuria. Again, you find that more intensive glucose control, it basically adds to the secondary albuminuria outcomes. So whenever you have a patient with CKD, you have to be very careful about the risk of hypoglycemia, and that is what your drugs are avoiding now. So if you have drug-drug interactions, you've got hepatic failure, you've got CKD stage 5, you've gastroparesis that is because of autonomic dysfunction. The drug-related factors like insulin, long-acting self-neuroderivative with active metabolites like leventhulmide, all of these drugs increase the risk of hypoglycemia markedly. The short-acting self-neuroderivatives or SU derivative with inactive metabolites and meglinotides, especially ripaglinide, they are basically intermediate in the risk of hypoglycemia because they are short-acting. But the wonder drugs that would basically be very low risk of hypoglycemia would be metformin, alpha-glucosidase inhibitors, DPP-4 inhibitors, including myomedics, thiazolidinediones, and SGLT2 inhibitors. All of them have pitfalls also in the management of glycemia and CKD, but they have a lot of pleiotropic benefits also that I'll be taking you through. Glycemic targets change as you move on to higher stages of CKD. As you can see, type 1 diabetes 7.5 to 8.5 in a patient with CKD 5, and 7.5 to 8.5 again in type 2 diabetes. Although HbA1c does have limitations in use as a glycemia indicator for patients with CKD because they may be on erythropoietin or they may have anemia, they may have iron deficiency, and so on that can change HbA1c. Drugs for glycemic management, we've got a lot of drugs with dose modifications. The important thing that I wanted to show in this slide is that you have got drugs like linagliptin now that do not require dose modification. You've got drugs like dapagliflozin that have gone to up to an EGFR of less than around 25, and now you have got GLP-1 receptor agonists that you can go down, tailor EGFR of 15, and that basically is a very good thing because we all know patients with CKD would in fact die more of cardiovascular disease as compared to CKD. And any drug that can be very useful at CKD stage 4, CKD stage 5 to decrease cardiovascular morbidity, mortality, and also have renal outcome benefits is a welcome drug in which GLP-1 receptor agonist recent trials up to EGFR of 15, dapagliflozin with a trial of up to EGFR of 25 is a very, very good addition to the armamentarium. You look at the cardiorenal outcome trials, you only used to have the CVOT till about 2015. when you started having the major adverse renal outcomes in the EMPA outcome, which was a secondary outcome. And then the major adverse renal outcomes started, and you can see all the trials having the major adverse renal outcomes, be it leader with liraglutide, sustained with semaglutide, canvas, declare TME, dapagliflozin, exenatide, albiglutide, SGLT2 inhibitors joining the bandwagon, and you have artigliflozin again, which is not available in India, empagliflozin, and then DKD coming up, which basically was looking at patients both with and without type 2 diabetes, and the sotagliflozin trial, which although did not show any benefits in MARE, but you can see GLP-1 receptor agonists and SGLT2 inhibitors are decreasing the major adverse renal outcomes also. So exciting times for the treating physicians, endocrinologists, and nephrologists as the therapies that you had, the standard of care, these are very good additions to the standard of care that has happened in the recent 4 to 5 years. We all know the SGLT2 inhibitors, the tubular glomerular feedback is impaired in type 2 diabetes, has this hyperfiltration in early stages of diabetic nephropathy. And with SGLT2 inhibition, this hyperfiltration is reduced and you have restoration of the tubular glomerular feedback. Ingredient-based therapies target just about 6 parts of the pathophysiology of the glomerular stalk chart, but in the kidneys, they have a lot of targets and there are a lot of benefits that are happening in the kidneys by decreasing glycemia, decreasing dyslipidemia, decreasing obesity, proteinuria is decreased. There is xenoprotection in type 2 diabetes. There is decreased inflammation and pro-fibrosis. Fibrosis by TGF-beta dependent mechanisms decreased. There is decrease in systemic hypertension. There is decrease in global hypertension. And all of these by decreasing reactive oxygen species and other pathways, angiotensin pathways also leads to all the benefits that we see with the ingredient-based therapies. So these are even metformin, you can see the decreased AMP kinase, mTOR is decreased and has renal benefits, but you have to be careful in patients who've got an EGFR of less than 60, EGFR less than 30, you have to stop. And between 30 to 60, you have to be at half, 50% of the dose that you can give. Pioglitazone also, you can see a lot of benefits. Urinary albumin excretion, NF-kappa beta is decreased, CKD progression is decreased, but it causes salt and water retention, osteopenia, body weight may increase. GLP-1 receptor agonists, the new drugs on the block, body weight decrease, urinary albumin excretion, reactive oxygen species decrease, but nausea vomiting can be a troublesome factor, especially in patients with uremic gastritis. You can go up to a EGFR of less than 15 now with GLP-1 receptor agonists. DPP-4 inhibitors, again, doing a lot in the kidneys. Hypoglycemia is less likely because they are causing insulin release in a glucose-dependent fashion. SGLT2 inhibitors, decreasing hyperfiltration, body weight is decreased, blood pressure, urinary albumin excretion, reactive oxygen species decreased, but you can go till an EGFR of 25 with SGLT2 inhibitors. A lot of potential drugs in the armamentarium, and you can see NRF2 activators, peroxidinol. You've got the inhibitors of leukocyte recrutation. You've got JAK-STAT inhibition, Clotho, exogenous Clotho. You've got IL-17 low dose, aldose reductase inhibitors that probably our next speaker will be talking about. And there are a lot of off-target as also on-target actions. And there are some trials that they may have renal benefits also. So the drug started off with causing no harm, and now these drugs are improving renal outcomes, which is very exciting. You can see with in the DPP-4 inhibitors, with all the trials examined, TCOS and SAVOR-TIMI, there is no worsening of nephropathy. With GLP-1 receptor agonists, there is a benefit for worsening nephropathy, and SGLT2 inhibitors, again, a very good drug for the renal outcomes. So if you look at renal outcomes, it all started with being secondary outcomes for the kidneys. If you look at empagliflozin and dapagliflozin, but canagliflozin in the credence renal arm was looking at the progression of CKD as a primary outcome. You can see the effect on primary outcome, CKD progression credence was decreased with canagliflozin. And when they started looking at the kidney outcomes, all the gliflozins, they have shown benefits in decreasing albumin excretion or albumin-urea containing composite outcomes. Effect of GFR loss is there with EMPA, CANA, and DAPA, and you can have genital mycotic infections. So you can have euglycemic decay and an acute fall in eGFR when you start an SGLT2, and you can have a postural hypertension if the patient is on concomitant other antihypertensive drugs. That you have to be careful, but you have to balance the benefits that derive out of these drugs versus the risk that these drugs may have. GLP-1 receptor agonists also, if you look at all the trials, liraglutide, semaglutide, albiglutide, dulaglutide, exenatide, and lisinatide have shown benefits in the primary outcome, that is cardiovascular, but in the secondary outcomes, they have again shown benefits although pioneer 6 with semaglutide did not show evidence, but you can see they are showing some benefits. Exenatide, albiglutide almost neutral, but lixisenatide, liraglutide, and semaglutide are showing benefits on the renal outcomes also. Start looking at DPP-4 inhibitors. We've got these for a long time, and saxagliptin and linagliptin have shown the better renal outcomes as compared to the other gliptins. With Credence, DAPA-CKD, and SCORD with sotagliflozin, you can see the major renal outcomes are benefited. You can see the risk, the hazard ratio for mere outcomes is 0.66 with Credence. DAPA-CKD was 0.56, huge decrease, 44% benefit in CKD, and sotagliflozin, which is not available in India, the hazard ratio is 0.69, a 31% benefit. Credence showed benefits in end-stage kidney disease, death from cardiovascular causes, renal-specific composite outcomes, dialysis, kidney transplant, renal death from any cause, as this was from canagliflozin. Dapagliflozin also has shown similar benefits, renal-specific composite outcomes, death from any cause, a composite of cardiovascular death or hospital heart failure also. This is true for EMPA kidney also, empagliflozin showing benefits in incident worsening nephropathy and also in the post-hoc renal composite outcomes. This all led to a radical change in the guidelines, and ADA 2021 has started suggesting that you have to consider some drugs independently of baseline A1C, individualized A1C target or metformin use, and SGLT2 inhibitors right up there. You can see if the patient has TKD and albumin excretion, you have to prefer an SGLT2. You may have to remove other drugs if they are not providing the pleiotropic benefits on the kidneys and bring in an SGLT2, even if the patient is at target A1C or the patient does not have very high HbA1cs. So SGLT2 with primary evidence of reducing CKD progression or SGLT2 with evidence of reducing CKD progression in the CVOTs, that is basically a SGLT2 that has primary benefit, primary renal outcome benefit, or the secondary benefit, even if in the CVOTs you have to take into that, or a GLP-1 receptor agonist with proven CVD benefit if the SGLT2 is not tolerated or contraindicated, especially what can be a case in which the eGFR is very low. You can go up to 25 with SGLT2, and you can go up to 15 with the recent data that you have with GLP-1 receptor agonist. You can have both of them together also if the condition of the patient permits. So there is a paradigm shift in the management of patients with diabetes and CKD, in which after metformin or even before metformin, there is an opportunity to add a SGLT2 or a GLP-1 receptor agonist. This is replicated in the KDIGO 2020 guidelines. If you look at these guidelines, after physical activity, nutrition, weight loss, metformin, according to eGFR, you just go in for an SGLT2 inhibitor if the patient is eligible, does not have contraindications, and you can always add a GLP-1 receptor agonist to add to the benefit of an SGLT2 inhibitor, and then you can go on for the therapies that are less established for the renal outcomes like DPP-4 inhibitors, thiazolidinediones, alpha-glucosidase inhibitors, sulfonylureas, and insulin for the glycemic control. A lot of drugs you have to be careful. Pioglitazone, diabetic maculopathy can increase. Semaglutide has increased diabetic retinopathy. Pioglitazone can cause heart failure and fractures. SGLT2 inhibitors, you have to be careful for GTI, UTIs, acute kidney injury that can occur, or you can have decrease in blood pressure on concomitant multiple pharmacotherapies. Saxagliptin established heart failure is because in the SAVE-ATME data showed an increase risk of heart failure. GLP-1 receptor agonist, previous documented pancreatitis, if you have raised triglycerides, steroid therapy, patients with MTC, you have to be careful, and liraglutide, active gallbladder disease is a relative contraindication. Some new drugs that are going to be coming and are in trials are the selective CCK chemokine receptor type 2 antagonism, which is implicated not only in insulin resistance, so it would be beneficial in patients with obesity and pre-diabetes, also diabetes, but also in progressive renal injury. Overexpression promotes monocyte maximus activation and migration. And oral CCR2 antagonist improves glycemia, albumin is mount model, and European data has suggested that it can reduce albumin on top of current standard of care in patients with diabetic nephropathy. So if you look at pathogenesis complication, insulin resistance, hyperglycemia, dyslipidemia, hypertension, this is all what we are targeting. But we may be moving on to more the decreasing reactive oxygen species. We may be looking at advanced ligation products, the receptor for age, PKC, polyol pathway, exomin pathways, and we may be looking at the eNOS and the prostaglandin synthesis also that may be potential targets in the near future for decreasing the microvascular as also macrovascular complications, including nephropathy. These may be the new targets, and these are in trials with for potential drugs. We look at the endothelin 1 receptor agonists, the MRAs, anti-fibrolytic therapies. Cenerenone has been approved for diabetic kidney disease also this year. You have anti-age therapies, JAK-STAT inhibitors, NRF2 activators, NOX-L4 inhibitors of chemokines, cytokines, and a lot of data is being generated in mouse models as also human trials for all of these drugs, which may be potential for decreasing the renal outcomes in patients with type 2 diabetes and without type 2 diabetes also. A word about renal outcome data. We have inconsistent definition in trials. We have to have a standardized outcome reporting major adverse renal outcomes like 4-point MACE for CV outcomes. CV renal stroke outcomes, I guess, would be there for all the drugs. You only have CV and renal outcomes now, but you may have stroke outcomes also for all the drugs. This is what major adverse renal events may look like. Parameters to monitor treatment would be secondary outcomes. To decide for treatment would be primary outcomes. You may be looking at surrogate markers, intermediate outcomes, and hard endpoints. The surrogate markers, a lot of them, intermediate outcomes can be the decline in EGFR, the EGFR slope, and the UACRs. Hard endpoints would be the ESKD, initiation of RRT, quality of life of patients, histology, kidney tissues, death of renal causes, major adverse renal outcomes, and cardiovascular death. So a lot of data may be generated for a lot of drugs in the near future. So in summary, what I like to tell you is that renal status and glycemic status, they affect each other. There is a continuum that is happening. Renal disease affects glycemic status, and glycemic status would affect renal disease. Renal function affects monitoring also. HbA1c may not be a very good test. The goals of therapy are dynamic, and they will change with the condition of the patient. Many drugs have shown renal benefits apart from controlling glycemia that should be higher up in the ladder for treatment of patients with diabetic kidney disease as compared to other drugs which are neutral or may have detrimental effects. Renal outcome data for drugs like 4-point MACE need the R for a holistic management of patients with diabetic kidney disease. Thank you very much for the patient hearing.